Video will discuss about MI, myocardial infarction. How will define infarction of myocardium of heart due to decreased blood supply. So, infarction of myocardium of heart due to decreased blood supply. Here there are three reasons like HID or CAD. It can be atherosclerotic plaque, or it can be thrombosis, or it can be vasospasm. What are the reasons? The ultimate point is coronary obstruction. Either partial or complete coronary is obstructed. If the coronary is obstructed, there is less blood supply to the heart. So, it may be partial or complete coronary obstruction. Because of that, less blood supply to the heart. In angina, obstruction is happened during physical activity. When taking rest, it will gone. But here, once occurring, it is not going back. Here it is persistent, and that is leading to permanent ischemia, not transient. So, MI, there is coagulating necrosis. The cells in the left ventricle, these are the cells receive blood from coronary. Now imagine the coronary is obstructed. There is less blood supply to all the cells. All these cells will not receive blood, so they will start to dying. And the death of the cell is necrosis. So here no blood supply, so that cell become dying. So the death of the cell is necrosis. Here coagulative necrosis. It is an infarct area, that is MI. Next, etiopathogenesis. Coronary atherosclerosis, superadded changes in coronary atherosclerosis, that it may be thrombosis or calcification, then vasospasm. Now, types of infarct. There are two types. First one is full thickness. It is also called as transmural. Second one is subendocardial. When they occurring, the inner subendocardial, half of that myocardium. This one involved in entire thickness of that ventricular wall. This is lumen, wall of left ventricle. This one is the thickness of wall of left ventricle. This one is the bigger coronary. This red color one, bigger coronary vessels. This one is the small coronary coming inside, supplying the wall of the left ventricles. Imagine here there is atherosclerosis. No blood coming here. All the coronary not receiving blood or less amount of blood. Ischemia start from inner and start progressing in 24 hours. It involved throughout the thickness. After 24 hours, it involved in throughout the thickness. So there are two types of MI. First one is subendocardial partial obstruction. Only inner half is involved. It is known as subendocardial MI. This one is the larger one, is full thickness. This one is called transmural. Transmural means full thickness involvement. So these are the two type of MI. This one is subendocardial partial. Full one is called as transmural. You can see three diagrams. See the coronary. Currently, it is not obstructed. It is not obstructed. Just obstruction having at 0 hours. 0 hour the obstruction have started till now there is no infarct. Now within 2 hours the infarct is starting from inner side, so it is subendocardial, and within 24 hours it progress full thickness. It is converted into full thickness, so full thickness here. In fact, so subendocardial cover into the full thickness within 24 hours. It started from the inner side. This one is transmural. This one is subendocardial partial. This one fully affected. What is the location of infarct? It depends on the type of the coronary. We know three coronary. LAD supplying anterior wall, LCX supplying lateral wall, and RCA supplying the posterior wall. The center diagram is normal. Now you see the coronaries. Obstruction the three coronaries one by one. See LAD completely obstructed. Here LCX completely obstructed. Here RCA completely obstructed. You can see the corresponding obstruct. When LAD is obstructed, you can see anterior wall is showing transmural impact. These three things transmural impact. If LCX obstructed, the lateral wall showing that RCA obstructed, that posterior wall is showing that. You can see completely obstructed, the full thickness obstruction. Full thickness obstruction. Now the same you can see if partially. Here partial obstruction. Partial obstruction in LAD, LCX and RCA. So that subendocardial impact is partially obstructed. This one is completely obstructed. Completely obstructed transmural, partially obstructed subendocardial. So these are the two main type of obstruction. So transmural 3, subendocardial 3, totally we have 6 type of infarct. Explain about cross and microscopy of infarct. Imagine this person died. He was healthy and he was normal. He died. He having chest pain and died. The police is suspecting some foul play. So the death body came for post-mortem for the autopsy. Doctor supposed to take heart out this dead body and look for that infarct. Whether the patient having MI, yes or no. What is the timing of MI? Is the age of MI? If the timing of MI is correlating with the death of the patient, we'll say that case of the death is MI. If MI is present, what is the age of MI? So in postmortem, doctor want to answer 2 questions to police. Postmortem report If MI present, what is the age of MI and what is the timing of MI? Age of that MI. It is 4 hour old or 24 hour or 5 days or 7 days or 1 month or more than 1 month. So doctor will write that in the postmortem report and police will correlated that with the timing of the death. So for that, first we will take the heart. Suppose this is heart of that dead body we taken out. So this one is the heart of the dead body we taken out. Now what doctor will do? Doctor will cut in the slices, multiple slices. Each slice will cut at 0.5 centimeter or 0.1 centimeter. Now we have 100 of slices with us. Take all the slices in this container. Suppose this one is the container. Now we'll take each of the slice have 2 lumen, left ventricle, right ventricle. So the wall of the left ventricle we look for infarct in all slices left ventricle. Here a dye, there is a dye, name of the dye triphenyl tetrasodium chloride, triphenyl tetrasodium chloride. The container filled with TTC, triphenyl tetrasodium chloride. Take all slice of heart, pull at the slice here. So slice here. TCC gives red color. TCC gives red color to the viable area. Then TCC give pale color to dead area, pale yellow color to dead area. All these slices become red except the infarctor area which will be yellow. Complete slice red. It is a viable, but you can see that yellow portion. This is that infarct area. Why viable area red and non-viable area pale? Whenever there is ischemia, the cell burst. This is the cardiac cell. So this is the cardiac cell. It have nucleus. It have enzyme. The cytoplasm have enzyme. That enzyme name is called as dehydrogenase enzyme. During ischemia, the cell burst. So dehydrogenase enzyme is lost. So dead cell does not have dehydrogenase enzyme. The viable cell having dehydrogenase. So TCC bind. So TTC bind with dehydrogenase. This is the principle. So TTC bind dehydrogenase. So it will bind the viable. So it producing red color. Dead cell don't have dehydrogenase enzyme. It producing pale color. TTC bind with dehydrogenase. Only it will bind only on viable area, not in dead area. So it producing red color. Now microscopy. What is the age of MI? By using microscopy we can deduct. For knowing the age, you have to make the slide. Histopathological slide you have to do the microscopy. On cross we can see MI present or absent, whether MI present or absent by using cross. But if you want to know exact age of MI, you have to do that microscope. In microscope divided it a 10 time zone, 0 to half an hour, half an hour to 4 hours, 4 to 12 hours, 12 to 24 hours, 1 to 3 days, 3 to 7 days, 7 to 10 days, then 10 to 14 days, then 2 to 8 weeks. We know red color is that viable part, yellow color, that pale color is the dead cell. So pale color part we cut, then make slide and look the slide. In the slide what you are seeing, based on that decide your time zone. Here 10 time zone, 0 to half an hour, no changes is seen. The heart will be normal. 0 to half an hour the heart become normal.